Welcome everybody. Thank you so much for being here today to talk about enhancing eating disorder treatment, measurement-based care, and the value and impact that it has on eating disorders. We have a really great crew here today, and I'll get to introductions in just a second. But just want to give a quick overview of what our session's going to look like. We are talking today about measurement-based care, integration into eating disorder treatment, how we can track progress, personalized interventions, and ultimately how this is really a tool for us to foster equitable and patient-centered care. So we're going to have some intros, we'll do some presentations from both of our wonderful panelists, and then we'll have the chance to dive into some questions. So as you go through the session with us today, if you have any questions, please use the Q&A button that you have at the bottom of your screen. And if there is a question that you see that you want answered, give that a thumbs up, use the upvote feature, and we will try to get to those top questions at the end of our time together. And my last little reminder would just be that at the very end of this session, there will be a brief survey that pops up just to let us know what this webinar was like, content and topics that you want for future educational sessions. So just stick around to do that quick 30-second overview for us. And with that, I will jump into intros if we want to pull our slides up, and I will kick us off. Very formally, I'm Carson. I use they, them. I am our program director here at Project HEAL. Project HEAL is a national nonprofit, and we are trying to lead the movement to affirming accessible and affordable mental health care for those that are struggling with eating disorders. We do that through a number of different direct services, community care services, and capacity building. So our direct services include things like treatment access, free clinical assessments, insurance navigation, cash assistance, whatever we can do to help people who otherwise wouldn't be able to afford care or enter care get not only access to care, but quality care. And that's part of why I'm really excited that we're having this conversation about measurement-based care today, because we really at Project HEAL want to make sure that people are not just getting into care, but getting the right care that's going to fit them as an individual. We get to do that in large part because of our partnership with the Healer Circle. Our Healer Circle is a national network of over 280 providers who offer pro bono and sliding scale care to Project HEAL recipients. We have nutritionists, we have dietitians, doctors, therapists, treatment centers, all who help us to move care to those who really need it. Big shout out to Within, who is also on this call, for being part of the Healer Circle. We could not do this work without those partners. And because of all of that work, last year we were able to allocate $6.3 million in cash value of services through this organization, through the work that we do. So thank you to everybody who has been a part of that. And if you have any interest in learning more about our services, I would be your point of contact. Feel free to reach out to me. And with that, I'm going to kick it over to our panelists to introduce themselves. Jesse, do you want to kick us off?
Yeah, absolutely. Hi, everyone. My name is Jesse Heyman. I go by he, him, and I'm the Chief Growth Officer at Greenspace Health. First of all, I think following up with Carson, thank you for attending, for taking the time out of your day to learn about measurement-based care and its application in the eating disorder setting. Amongst the work I do here, one of the things I have the pleasure to lead is our educational initiatives, which we've been running for about the last 4 years, usually once every quarter, and bringing together some of the world's leading experts on measurement-based care, as well as treatment generally. And it's provided amazing educational opportunities for clinicians and clinical leaders just to learn about measurement-based care, understand its impact, and also how to apply it in different service settings. So very honored to lead that and to be a part of this. From a personal perspective, really excited for this conversation and honored to join Wendy, Carson, and both the Within Health and Project HEAL teams. Eating disorders are very close to my heart, and what originally got me into the working in the mental health space when I was trying to support someone very close to me that was living with the challenges of an acute eating disorder. And I realized how large of a gap there was on both the community education side in order to support someone struggling with an eating disorder or any mental illness really, as well as a large gap on the treatment side. And so since I've spent several years as a facilitator for a men's eating disorder group therapy program, and currently sit on the board of Sheena's Place, which is a leading eating disorder group therapy organization in Canada. So I will actually, maybe I'll jump in a little bit around the background of Greenspace Health as well. So we're the leading measure-based care technology company in North America. We support organizations to implement measurement-based care across any service setting. We started out of a research hospital in 2015 to bridge the gap between the significant and positive impact of measurement-based care shown in research and its actual implementation in real-world clinical settings. So if you fast forward to 2025, we've supported over 500 measurement-based care implementations across small clinics, community clinics, hospitals, health systems, insurers, really all settings across the behavioral health ecosystem. And from day one, the mission was and still is empower mental health systems and providers with the technology and insights they need to provide the best possible care to the people that they're supporting. I think just very quickly, for those that are new to measurement-based care, I just want to share what I see as like the largest piece to explain the difference between traditional measurement and measurement-based care. So traditional measurement is a reporting exercise that doesn't provide clinical value throughout the treatment process, but just an indication at the end of care whether a person has improved, and also doesn't let you know why that improvement has happened. Measurement-based care essentially flips that model on its head by making it starting first and foremost with clinical value for the client and clinician, which helps keep them engaged in the process, informs care improvements, and helps just make the service quality better overall. And then clinical leaders can leverage that data to inform quality improvement as well as funding, obviously. But I think first and foremost, and the most important part of it is it starts focused on clinical value for the client and clinician, and that needs to be the main driver throughout any implementation. So anyways, very excited for this discussion. Really appreciate you all taking the time out of your day to be with us, and I'll pass it back to Carson.
Thank you so much, Jesse, and so excited for all of the knowledge and expertise that you bring on measurement-based care into this space. I'm going to kick it to you in just a minute for our opening presentation. But first, Wendy, do you want to introduce yourself and within to the group?
Absolutely. Hello, everybody. I'm Wendy Oliver Pyatt. I'm a psychiatrist, go by she, her. I appreciate being here very, very much. We have a little bit of background about Within in case somebody in the audience isn't familiar. We are an intentionally remote treatment programs for eating disorders specifically. So the problem of the pandemic kind of bred this opportunity to create this comprehensive program, which we call Enhanced PHP and IOP. And the reason that it's enhanced is there's really nothing available to patients in their home setting that matches this as far as like the extensive amount of clinical care that's delivered in the home, intensive family therapy that's done, family coaching, family psychoeducation, which is really great to be able to access the home environment where the family is. It's really makes easier access. All of our patients have access to nursing, so we're able to work with a fairly acute population, so we can do earlier treatment and disrupt the progression of an eating disorder. We do work with a lot of people who have been in and out of treatment and just burned out from that roller coaster ride of going away and then coming home. So we work with a lot of people who've been called treatment refractory. But I do think, and Jesse and I were talking about this, that one of the things that we've really learned is that patients have really needed this kind of care that bridges the gap between a brick and mortar experience and being in their home environment. So the problem became the opportunity. In fact, I had started doing virtual care, remote care before the pandemic, and I really got excited about doing that because I was like, this actually can work. It does need to be done in a really clinically responsible way when you're working with these sicker and sicker patients in the home. We do really get excited about increasing access. We say we want to provide care to everybody, everywhere. And we work with all diagnoses across the spectrum. We can work with, in a very unique way, with special populations that in traditional brick and mortars, there may be only one or two persons with RFID or a male or so we are able to create these milieus within our milieus, which is something that patients really, really enjoy. We do have an app that all of our care is delivered through, and the app doesn't replace the relationships. It enhances the communication, it enhances the follow-up, and we're able to work with patients all throughout the day. We don't just work with them for 3 hours or 6 hours. We have connectivity all through the day with chats, supports, and monitoring, meal monitoring. So there's an intensive amount of support. All of the patients have a high frequency of individual therapy, psychiatric management. And we've just super excited. We really looked very thoroughly through all the potential measurement-based care platforms. Dr. Caitlin Shepard led the way. And that's when we found green space and decided to go. But this was a very intentional thing that we did, doing measurement-based care from the very beginning. And we really thoroughly vetted every potential option and then found green space.
Thank you, Wendy. Really
Yeah.
excited about all of the work that Within is doing. I know at least at Project Heal, our recipients deeply value and appreciate the access that so many of them are able to get through Within. So really
Thank
glad
you.
to have you here.
Thank
And
you.
with that, just a quick reminder to everybody, we're going to launch now into Jesse's presentation, doing a quick intro on measurement-based care and its impact on eating disorder treatment. If questions come up for you throughout that presentation, pop them in the Q&A and we will get there when we wrap up. And with that, over to you, Jesse.
Thank you, Carson. So I'm going to start with some of the data. There's pieces on screen that you can read through, but this may be not news for a lot of the people in attendance, but eating disorders have the second highest mortality rate amongst any mental illness. Only about 20% of the people that are struggling or challenged with an eating disorder will access the support they're looking for. And then I think a big piece here is the prevalence side. So if you look at 2000 to 2018, global prevalence went from 3.7 to 7.8 on average from a percentage perspective. Now, if you take that and add in the fact that funding for eating disorder treatment services and research historically has been very low. And if you look at it recently, just in 2023, 10 times less funding towards depression than eating disorder services, which was 55 million versus 500 million. And even when you normalize for prevalence, the number is still fairly staggeringly low. To wrap this slide up, people are struggling. The criticalness of those struggles is very high. They're not accessing the support they need, and the right funding isn't in the space to really help drastically improve. And so working in the measurement-based care space, I've seen the impact measurement-based care can have on general services and the impact it has and can have on eating disorder services. So that's why I'm excited about this conversation and the potential of like the prevalence of eating disorder implementation across eating disorder care really growing rapidly. So before we hop into that, we can jump over to the next slide, and I want to just kind of level set on what measurement-based care is. So this will be a quick one. Quite simply, it is the collection of patient-reported outcome measures throughout care and leveraging those outcomes to inform clinical decisions and discussions with clients. It represents a very large shift in the industry from treatment where measurement and outcomes were largely unknown to where data is used to inform the care process and ensure we understand when treatment is working, when it's not working, and can adjust accordingly based on that. And so jumping into going from the high level definition of measurement-based care to how it can help, we know that measurement-based care will improve care at the individual level. And we've seen that across many different care settings in both our research and in both research and our data. It helps individuals better understand their mental health. Because of that, they can better communicate their needs in care, which is a vital piece for eating disorders, considering that the way they present in people range so widely. Clinicians can then identify when they're improving, more importantly, when they're regressing, and identify and address it before that person may regress into crisis or more acute or have more acute needs. And then on the equity side, people coming into eating disorder treatment and treatment generally are coming from all sorts of demographics, backgrounds, experience with mental health care, comfort speaking about their mental health. And one of the things I think from an equitable perspective with measurement-based care is it allows people, regardless of their background and their experience, to learn about their own mental health and build a shared language with their clinician where they can communicate their needs and care, they can communicate their goals, they can speak about their experiences in a way they may not be able to if that data and insight isn't there to help inform and help them learn about their own mental health and communicate that with their clinician. Then if you move to the clinical level, clinics can better understand what services and programs are working and for whom, which provider is a better fit, and leverage your data to inform quality improvement to drive better outcomes and a better quality of care. So we improve care at the individual level, we drive improvements on treatment quality, and at the clinical and system level, we know that funding is becoming more and more reliant on showing your outcomes, both through value-based care and just general grant and RFP streams. So on top of quality improvement, clinical leaders are empowered with the data they need to ensure more funding starts funneling into the eating disorder space. So I just want to jump into two slides here that are focused on data. This one is more around usage data on green space. If you look at participants, that might be a interesting term for you. So participants is mostly clients or patients in care, but it is sometimes a caregiver, teacher potentially, but someone else that is participating in that care process in some form with them. So they may be taking an assessment or just supporting them throughout that care process. So that's what participant means. I want to jump to the 83% assessment completion rate. One of the biggest questions we get asked in measurement-based care is, will my clients do this consistently? And what we have found in our data and in the implementations we work on is that if it is introduced to a client where the value is shared with them and how it is going to be used and provide value throughout their care process, and then actually used throughout the care process to inform discussions, make decisions to again work collaboratively together, they will engage and continue to engage. But the important part, and that goes back to my original point of clinician and client value, is they need to understand the value in it for them, which traditional measurement wouldn't have provided. And so we can jump to the next slide. So I want to focus on a few things here. There's a program called the NHS Talking Therapies in the UK. It is the largest global implementation of measurement-based care. They started in 2012. And when they started, their symptom improvement in that first year was, I believe, 35%. They're now the last I saw, in 2024, they brought that up to 51%. And they fully credit it to every year we're using measurement-based care, driving improvements at the clinical level, but also using that to change our programs based on the outcomes that we're seeing and the insights we're seeing. So we're really proud of the 49% average symptom improvement across all of our clinics. The second thing I'll highlight is 81% therapeutic alliance. If you look at the chart on the right, you'll see a pretty big jump from one assessment to two, and then a very slight ladder, or let's say small steps moving forward. But that big jump from 1 to 2, I think, makes a lot of sense in that your provider and the provider and their client have a better understanding around what that person's challenges are, better understanding around the specific symptoms they might be looking to work on, which would likely lead to better bond, better trust between the clinician and client. And we know that therapeutic alliance is the #1 predictor of positive outcomes in care. So that's a vital piece. The second piece is symptom improvement on the left-hand side. You'll see a much larger step ladder, a much steeper step ladder, where the more assessments a person completes in care, the better that they do. And we see this both in the research and our data across 500 implementations and hundreds of thousands of assessments. The more assessments a client completes in care, the better they will do. We also see this in a population health self-guided setting as well, but we'll stick to clinic setting for now. This is correlation, not causation. The assessments empower providers and their client to take a lot of actions that provide significant value in the care process. So it's not that the assessments are directly leading to symptom improvement, but they're unlocking a more impactful and more patient-centered care process that allows them to see better outcomes. And I think that is something we see across the board. Bottom line is, the more assessments someone completes and through the process of measurement-based care, the better that they will do. I think the next question that comes up after looking at the data is, okay, that's great. How do we get there? And so I'm not going to jump into deep implementation thoughts. We don't have the time for that. And also Wendy is going to jump deeper into that for eating disorder specifically. But I do want to highlight our 4 C's. So this is across all of our implementations, 4 pieces that are foundational components of any measurement-based care implementation that should always be there. And I'll just explain each one briefly. Consistency refers to frequency. So the frequency of assessments to a client in care. Generally, we default to biweekly, but most evidence-based assessments will have a recommended frequency. The key piece here is that the more frequent they can complete assessments, the better off it's going to be, because they are going to be in a much better place to be able to identify why those changes are happening, to speak to their experiences and their provider to understand and pick up nuances in their experiences and their data that may lead to a better understanding of that person and how to support them to progress throughout the care process. So consistency is key, and more frequent, the better. Second is client visibility. That is an easy one. It is just that. Client should, in most cases, have the ability to see and track their own data so that they can build a better understanding of their own mental health. They can more proactively participate in the care process and communicate their needs and their experiences to their provider. Third piece is customized. There are 2 pieces of customized. The first is that dependent on the program. So let's say it's eating disorders, substance use program, anxiety and depression, the battery of assessments that you use is likely to be different amongst each of those based on the challenges that you're supporting people through. So that's one piece to customize. There should be the ability to customize the battery of assessments used within each program. The second piece is that a clinician should have the ability to easily customize the assessments being used for an individual based on their specific needs. So let's say you're working in an eating disorder program and you learn that that person also struggles with some substance use. You might want to add on the craft assessment. That should be really easy to do so that you can better inform their treatment, align it to their needs, their goals, and just what they need overall throughout the care process. If you go back to the NHS Talking Therapies program that I mentioned earlier, they ran a study where they looked at their providers that just simply used the regular battery of assessments, which is a great thing to do, versus providers that had assigned an additional custom assessment, at least one or more additional custom assessments. The symptom improvement on the providers that had assigned at least one additional custom assessment was a 28% symptom improvement above others. So the impact of tailoring care, including assessments to the individual you're working with, is really high, while also not impacting the overall quality of the data set because you're still using the regular battery of assessments for that program. And then the last piece, and I think you probably get this from everything that I've said thus far, is that collaboration is a very key part of the process. If you're not collaborative and following the process of measurement-based care, which includes reviewing the results, discussing them, and acting on them, and making decisions together with them, your client is very quickly going to lose interest because they're not seeing the value in the process. And so they may not complete the assessments, and then obviously measurement-based care is not working very well. So it's really important, both for the clinician and provider, that it's collaborative because both of them will see the value of it through that. And so with that, I'm going to wrap up there. I'm really excited to have this conversation because I've seen the transformational impact of measurement-based care time and time again, and understand the immense impact it can and is having on the eating disorder space, but especially the impact it can have given the criticalness of eating disorders, the growing prevalence, and the real need for research and funding in this space. So thank you so much. Excited for the rest of the conversation, and I'll throw it back to Carson.
So much, Jesse. And yeah, I was really tuning into the piece you're speaking to of how this is so impactful for each individual client and how that changes the patient experience, but also how important it is that we have this information for this field. Because being able to advocate with insurance companies, with providers, with people who are funding this work to show the impact of this care, it's so vital. So thank you for highlighting that. Before I take it to Wendy, just a reminder for everyone, pop your questions in the Q&A. I see a few have already come in there, so maybe we'll be able to type some answers to some of the quicker ones, but we'll get to those at the end. But for now, I'm going to kick it over to Wendy if you want to talk to us about your experience with measurement-based care at Within.
Thank you so much. This is just a real joy. I'm going to talk a little bit about the history of measurement-based care and eating disorder treatment as we go through the talk, because I think that's relevant to what we're all talking about, really progressing care for patients and progressing advocacy. It's really, really vital. I would not be able to start this talk without acknowledging the incredibly hard work and the grace of Dr. Caitlin Shepard, who is our clinical research director at Within. She did so much work just vetting the measurement-based care platforms and implementation. Very, very patient, helped our team get ready to help set really, really high standards for how we do this work. And I've just learned so very much from her. And so she really would be the one that would have the most knowledge in giving this presentation, but I'm honored that I get to do that. But a huge shout out to Dr. Shepard. And then our Chief Clinical Officer, Rebecca Brum, just works side by side with Dr. Shepard. And really we convey a very strong essence of this being vital. And I think as far as like the collaboration and getting these measures and having the high expectations for measure completion, that just starts from the top down. And at Within Health, it's just a baseline. It's an absolute expectation. And if the measures were not done, we track the completion rates. And every single month we're seeing, where we might fall off, like for example, if the patient leaves AMA and things of that nature that come up. But from the top down with Dr. Shepard and Rebecca, we we are very focused on that. Dr. Jessica Janae was the first person that really introduced me to measurement-based care back when we worked at OPC many years ago, and she was the one that got our program started here. She really wanted to do other things, but we didn't have Dr. Shepard yet, and she's been such a blessing. And then Kelly Roth, she's our VP of Operations, Quality, and Compliance, and she's all things to us in so many different areas and worked really hard with Green Space to get this process going and maintaining a really healthy relationship with Green Space so that we can get the most out of this, this opportunity to do measurement-based care. So going to the next slide, before I really dig further into measurement-based care, one of the things that sort of brought me joy was the evolution in our field from this idea that the only thing that is evidence is a research that's a double-blind, placebo-controlled study, and that's what evidence is, and anything else and anybody else like doesn't matter. That's the only thing that really proves anything. And that was really, really invalidating for me personally, because I had lived experience and I had clinical intuition, and that's what was guiding me. But it was sort of like, if you can't prove it through doing, these particular tests, then, it's sort of worthless. And that's really how the field was when I came in 2003. And those of us with lived experience, there was a little eye rolling of like, what is she doing in the field, And so understanding what evidence really means is like a foundation to understanding measurement-based care. And evidence-based practice is using the best available research. So yes, it's incorporating research. It's also incorporating clinical expertise. So yeah, my experience actually does matter. And then the patient's characteristics, their values, and their circumstances. Another beautiful thing that we're seeing in the field now is this movement in the direction of harm avoidance. And we hear about that a lot. And that allows us to more align with the patient and be able to work with them where they're at, and recognizing not everybody's going to get to the exact same place. And we're really wed to that at Within. We do work with a very high acuity at times, and sometimes we want them to be in different settings. And if we can't get them to do that, if we can safely work with people and give them a chance, we always try to do that. But that's what evidence-based really is. And it really allows for lived experience to matter. It really matters what the patient's values are. So it really elevates, I think, the whole treatment experience to be more humanistic. So that's very exciting to me. And I think we already talked a little bit about what measurement-based care is and what the components are. But it's just this collect, share, act model, which you can kind of keep in your mind. And it's really important in your organization. I mean, we at Within, I mean, everybody knows that if you don't do the measures with your patient, like that's not acceptable. And that bar is really high. It's not like a side note. And I think that's one of the things that's happened in the field, is that in the very beginning, and I'll talk more about the history, but people weren't even doing measurement-based care. And then it was sort of like an add-on, but it wasn't, it was more like pre and post, and maybe people looked, maybe they didn't. And it wasn't really, it wasn't really something that was, it was taken serious, but it wasn't incorporated into the patient's life in treatment. So the collection part really also involves explaining the rationale for measurement-based care and discussing the measures that you're choosing and why, and then repeatedly administering these measures so at specific points throughout the treatment. And you'll find we do it every month. And then sharing the data. This is the thing Dr. Shepard's really strict with. And she's like, come on, guys, this is what can fall off really easily, I find, is getting that sharing piece back to the patient as quickly as possible. And that's always a conundrum, because we want like the partnership meeting, we want the multidisciplinary team there. And so getting that feedback to the patient quickly is a really important piece of this. And then acting on this care, acting on the measures is really important too. I've seen and learned from doing measurement-based care, for example, with body image disturbance, time and time again, the person's like healing and getting better and looks better, but their body image stuff is going up and up and up and up and up. And that's right when, of course, everybody wants to turn their back on the patient. The insurance is like, oh, they've weight restored or whatever, they're eating more. And the patient is actually really struggling. Like we providers or family, we're relieved, like, oh, they're doing better. Look what they're doing and how they're eating and all that. And then you look, at the body dysmorphia, indicators on the measurement-based care, you see they're going up. And interestingly enough, there's really interesting trends I've seen where, you wait it out 2, and now you get to 3 months and it starts to go down. It just follows the exposure curve, but it's chasing all the other symptom improvement. And a lot of times patients get discharged right when they're actually feeling the most fragile in certain ways. And we're kind of letting our guard down because, oh, look what their behavior is. So looking at all the data using measurement-based care can really help you be careful about not skipping something and not missing something just because you kind of feel a little bit better. Next slide. And so the other thing just to keep in mind is measurement-based care is not protocolized treatment. That's one of the things I thought in the beginning, like, oh, they want me to do all these, it's going to be so strict and I can't really be a clinician, but it is not that. It is really bringing together the art and science of treatment. So that's important to note. It's not a strict protocol. In fact, like Jesse was talking about, can be very creative, and you add specific measures, which we can talk about some of those specific measures later on. And this people can read this on their own. I don't want to take up too much time, but it gives some language that can help providers find, the correct rationale, like how we can get this language across. I am going to kind of go quickly because we got a little of a late start, but this will be available and you can just read this and help you find your language. You sort of have to practice and find the language that works for you. Next slide. And this, again, you'll get this slide so it can help you a little bit here, but this is such a beautiful slide when you really dive into it, because it starts off, and this is the sharing, you're explaining and reviewing the total score, like your PHQ. Now I'm going to give you a patient. I'm going to tell you about a patient as we go through the rest of this talk. And we're going to see that patient's outcomes at the end of the talk. So there was a patient that came to Within that was a 32-year-old male that had a prior history of an eating disorder that began in college and began with a more presentation of restricting anorexia nervosa, and had some periods of stability, but really, really went downhill before admitting to Within. So that patient, in a nursing assessment, the nurse actually was the one that noticed his PHQ-9 score was 25. So this patient was saying in the sessions, he wasn't saying, I'm severely depressed, I'm miserable. He was more just saying, oh, I feel indifferent, I don't really enjoy anything. But he wasn't really even advocating depression. He just thought, life isn't worth living type of comments, but not suicidal. But so the level of depression didn't really show up in an interaction of just talking to them and even denying actually feeling depressed. So being able to go over that score and say, this score indicates severe depression. I'll tell you as we go along a little more what happened with this person. He was on 20 milligrams of Prozac only at the initiation of this conversation. So in the conversation, though, some of the interesting things that you can ask the patient, does how you're feeling match what the score is? For example, he's not necessarily saying he's really depressed, but look at this score. This is really, really high. And you can explore the discrepancies between what they verbally are saying and what the score actually shows, or even within a measure, one person might say in one question that they're not worried, and then in another question might be like, my mind is racing and I can't sleep at night. So you can explore these discrepancies, and all of this really just exudes that you're interested in the person, you're interested in their inner world and their experience, which really enhances the therapeutic alignment and a sense of attunement. It exudes that you're competent, exudes that you're detail oriented. And I think ultimately it actually helps the patient trust you a little bit more and feel safer. Next slide. Mechanism of action is really an interesting slide. I'll give you a chance to look at it in a little deeper way when you get the presentation, but it really does help engage the patient and pull them in. We get a lot of patients in our program that are sort of I'm fine patients, and I always say they have the faulty alarm system. Like they're very, very upset about eating a piece of toast, but not really upset about they have amenorrhea or stunted growth or something like that. And so we have to find this is a different tool to engage patients. So if somebody's less communicative, it can help with that. And it's a signal to the provider also of a need for action. And then when the provider takes action, I think the patients actually feel more secure and they feel safer, like this person's really paying attention and is taking me seriously, taking my symptoms seriously. Next slide. So we're going to get a little bit into the things that we kind of went through at Within. So when we started Within, that's why I was mentioning Dr. Jessica Janae. I don't know if she's on, but thank goodness for her, because I said, look, we're doing something completely different. There is no level of care like Within. It doesn't exist. It truly is enhanced care. We can, we do bring patients food into the home. We're making sure we're doing the exposure therapy. It's just a very intensive service, and we had to find ourselves out, would this actually work? So an assumption is that maybe the patient won't stop their destructive behaviors unless they're in a brick and mortar, or that they won't be able to weight restore, or they won't form bonds with each other. So these are some of the things that people thought about remote. And then some of the things that people feel about patients who, quote, fail brick and mortars, like, oh, they don't really want to recover, or there's that idea like the clinician should work harder than the patient. If the patient doesn't want to leave their home and go to treatment, oh, they just don't really want to get better. They haven't really hit rock bottom. And so there's this idea that they're resistant and just, basically being defiant in a sense. In reality, when you work with these patients in their home and you get to know them, it's like they often have either they might have treatment trauma, or they've been on the roller coaster ride of in and out, and they haven't had the soft landing that Within can provide. They've sort of given up hope sometimes. They have family that they have to take care of, so they can't go to treatment. They need to have insurance. There's so many different variations that don't have to do with the patient just not giving a hoot about getting better. There's just so many practical realities. And this model of care has helped us work with both early onset conditions to like nip it in the bud and stomp it out, or these later onset presentations. So historically, I wanted to share a little back in 2003 when I started my first treatment center. Really, nobody was really doing measurement-based care, but I got on to, I found the EDEQ, and I found something called the SF-16, I think it was, which was it was a quality of life measure. And so we were just doing it by paper, and I wasn't even really keeping track of it. I was just like, I'm going to do this. I'm going to keep track of it. And luckily I had a clinical psychologist that ended up working with me, and she was able to put this together for me and create some graphs out of it. But it was really like rudimentary, and it wasn't really done all that much. And then I had the thing that really got me excited. I had a clinical psychologist that was working for me at Center for Hope, and she ended up wanting to do her dissertation on what we were doing. She was so fascinated by what was happening. So that really opened my eyes, because then she started showing me more and more about measurement-based care. And then as far as the field goes, so there was an organization called the Red Sea, which at the time when it began in 2011 was considered the Residential Eating Disorder Coalition. And now it is different. It's representing Eating Disorder Coalition, because it's not just residential. And the Red Sea began a multi-center really an analysis of the effectiveness of the effectiveness of residential treatment. And that was using the EDE, the EDQ, the EDQOL, the STAI, and the PHQ-9. And at that point, once that got going, a lot of programs did start using measurement-based care. But I still think it's only like 20% of programs that actually use. Next slide. The other point is to just remember that what Joint Commission requirement is versus what Jesse was talking about, the 4 principles of measurement-based care. There's some alignment, but not all alignment. And I think the most critical things that are where there's not really alignment is the collaboration, the client visibility. So the Joint Commission doesn't necessarily say you have to share it with the patient. You just have to use the data to inform your goals. And core principles of measurement-based care it's consistent, but the collaboration and the client visibility is really, really important. And then of course, customized too. So there's some wonderful measures. Once you get into green states, if you do this, it's like, I'm like a kid in a candy store. I'm like, I want to do this. I want to do that. There's so many interesting measures. We don't use all of these. One of the things I'm going to kind of say is like, it's okay to start slow and then to just build up. But I just want to help people understand the importance of the collaboration and client visibility, because Dr. Shepard has taught me that, and I do understand why it helps the patients. And I'm going to continue to tell that story. of the nurse who saw the patient in what we call physio check and started talking with him about how high his score was. And we'll keep going on that story to lead to the end here with that patient. She did actually get the psychiatrist hadn't noticed that score. And that's another thing that's a thing that we have to work on, is making sure the psychiatrists actually look at the score every single time. I have made a little rule that in staffing meeting, you put the score up. So everybody that's there, you put the most recent measures up to be sure everybody's seeing them. And you have to designate somebody who's going to go back and read those results and share the results with the patient. But it was important for us to really differentiate within also, like, because not all PHP programs are the same. And so we wanted to have measurement-based care to show, like, hey, when we provide this level of care and this level of intensity, something different may happen than a traditional PHP or remote PHP or IOP, because it is actually a different level of care. Nothing like this exists. And that includes the meal delivery, the ERP that we're doing with food, the real life, the intensive family therapy, the availability all throughout the day, the platform, really giving the patient the right dose of treatment so they can go up or down in the number of hours very smoothly. And we can even provide up to 3 meals and 2 snacks that we work with really, really sick patients, and a really highly trained nursing and psychiatric team. So that's the enhanced and within's enhanced. And we felt like it was very important to really be using these measurements to show the difference. Next slide. And we just had to figure out before we got started, like who was going to get involved, what measures. That was a big one. Woo, that one was a doozy, figuring out what, where, how are we going to administer it, the start date, the frequency, the timing, and then the why, the established clinical use and organizational goals, and the how. And one of the things that we've done is we've continued to use measurement-based care post-discharge, which is a big thing. But it's okay to start small. Just pick 2 measures and go from there. Next slide. We did I'm saying we, Dr. Shepard and others did a really great job actually getting into the mind of our clinicians to figure out how did they feel about doing this. So we dug into that as a lead into starting measurement-based care. And we found that if you can look at the green on the bottom, was like the staff felt like they could do pretty well with it. And the purple was like they felt like they needed to improve. And so they felt at the very bottom, they felt okay about choosing and brainstorming, but appraising was a little bit different. They felt more confident of presenting and sharing than they did necessarily administering. So this just helped us dive into what our clinical team felt about this. And if you want to talk to Dr. Shepard about how she did this, please just let us know. I'm sure she'd be happy to share that. So some of the challenges with measurement-based care is the staff feeling unsure, not knowing what to consider when ensuring that it's viable, feeling comfortable explaining the measures. That's a big one, feeling comfortable explaining. And so you kind of have to really spend time as a clinician. You have to be committed to learning more. Dr. Shepard created a cheat sheet for the staff, which has helped me a lot, by the way. And then really making it a standard collaborative process within the milieu. Next slide. And the timing is also really important. And I think the key here is that what my take-home point is that it sort of becomes the fabric of treatment. It is really a part of treatment. It's not a sidekick. And really finding these ways to make sure it's happening and dedicating a session to discussing the patients, ensuring during staff meeting the measures are shown on a screen in some way. And what happened with that patient is the patient I was mentioning that ended up going from 20 milligrams of Prozac after that conversation. Oh, maybe I am actually depressed, and ended up getting on 80 milligrams of Prozac, and 2 milligrams of Abilify was brought in. But it was really becoming a part of the treatment experience with the psychiatrist, and really now tracking things very, in a very good way, in a very effective way. And the patient didn't really even know that he was depressed. He didn't really have the words for that. Next slide. Yeah, here's the measures that we're using, the EDEQ and the clinical impairment assessment. We got away from that Dr. Shepard enlightened me, and the PHQ-9. So there's a lot of other add-ons, and we're using other scales as well. We're using the GAD-7 instead of the STAI now. Next slide. And this just shows you the core measures, the EDEQ, the CIA, the intuitive eating scale, QH9, and the GAD-7 is what we're using within right now. Next. And there are measures that you can use for diverse populations. Next slide. And this just shows different gender identities, what the community norms are for shape concerns by diagnosis. So there's different norms for what you might expect on shape concern, and that might really inform your treatment as well, and paying more attention to shape concerns in specific populations. This just gives you an example of the avoidant restrictive. So for ARFID, we are using this for ARFID patients. It's really, really helpful. So you'll be able to see this in the handout. The next slide. The Rosenberg self-esteem scale, I'm super excited about it because it's one of those not directly about an eating disorder, but around a core aspect of eating disorders. So I was really excited to see this and how we can bring this into care to enhance our focus on how we're working on self-esteem with a patient. This slide just really makes it very clear that it's not just measurement-based care that's helping you with the appraisal. It's all these things brought together. The measurement is really woven in. It's part of the fabric, but you're looking at patient experience, behavioral observations, certainly looking at our providers, and ask your care partners, ask the ones that are eating with your patients, ask the ones outside of session, not just the clinicians who are with the patient in the session, getting collateral information, looking for self-monitoring, which we do a lot of meals and other self-monitoring tools, and we give homework, and then the physiological indicators. Next slide. And we already talked about this. We do it at monthly at treatment and discharge and then beyond in the through the alumni program. Next. The key impacts is that it's really engaged this team in a fact-finding. We were able to see trends within certain groups. It is actually very validating for us that, hey, what we're doing is really effective and it feels good, especially we needed to know that because we're doing a level of care that's pretty intense for some very fragile patients. So that was really important. And certainly with payer partnerships as well. Providing patient data back to the family. Next slide. To help them make good decisions about treatment. Building stronger relationships is really important, whether it's the payer, the family, the referent, and it really just helps. It helps us place the importance on working on different symptoms that are still prevailing that we're able to identify. And I'm just going to show you, this is the patient I was telling you about. He ended up getting on 80 milligrams of Prozac and 2 milligrams of Abilify. This was a recent discharge, and I just happened to see this one right before I did this presentation a few days ago. So the team was able to put this up for me. So you can see the drastic change in the PHQ-9 and all the scales, and it's just a really validating experience to see something like that. It definitely affected his care because that PHQ was really what alerted us that he was much more depressed than he was actually articulating. I think it actually saved his life. And some of just the best practices is really technology enabled. Having a champion, like having somebody, who's really like having a team. We had sort of a team that was really committed to doing this. Next slide. Just really the training and the support is super, super important. Having fidelity to the model, and then the graphs. Of course, the graph makes us very happy, and sometimes the graphs make us unhappy, and we have to deal with that as well. And then we use it first for patient care, second for quality improvement, and third for research. But it's the pillar of all of this work that we're doing at Within. And we want to just continue to do better and better. The biggest thing I'm focused on is getting post-discharge assessments so we can see how people after they leave. That's one of my biggest focuses. Thank you guys for listening as I was racing through my slides.
You did a fantastic job. And I just want to say, for some people who made a note in the comments, the recording will be sent out. So I expect everybody to go back through and pause and read those slides in details, because there's such a wealth of knowledge coming from Wendy and Within at large. So there's so much you can take away there. But thank you so much, Wendy, for presenting and giving us so much incredible information. We've got a good amount of questions in the chat. We probably won't get to all of them, but I will take us through at least some of the top questions. And then I am sure that people will be willing to share additional information for contact if you want to learn more, follow up, any of those things. But our top question I'll pose to Wendy and Jesse is someone talking about client-reported care. They say, so often with youth, getting the whole picture requires parents or family guardian input. So family involvement is really essential with youth and eating disorder treatment. Could you speak a little bit more about how you might include family members in measurement-based care?
Do you want to start with that, Jesse, or you want me to take?
You go for it.
Yeah, I mean, it's just our families are a part of our treatment bubble. They're a part, it's family or significant other. It may not be in a family, it's whoever's in that person's life. And we're really big on like obviously we have to get a release of information for somebody legally adult, but we absolutely use measures for families and make sure for younger folks that the families are also getting the measurements back as well. We actually had a patient that got prematurely cut off of treatment, had stepped down to IOP and got booted out, and his measures spiked up. And that actually helped us with the insurance argument, but it also really helped the family. So sharing with the family is really important, integral to what we do.
I'll say two quick things. One, I think from a technology perspective, it's really important for the parent or family to be able to participate if it's helpful. So in some cases, an assessment can be completed by a parent. They could be given permission to see their child's results if that's something that's appropriate, so they can participate in that way. The other side, and Wendy, this goes back to a conversation we had yesterday, is so often eating disorder treatment, a problem with it is a person is in care, and let's use inpatient as an example. They go home after having all this support and inpatient care, and their family doesn't know how to support them. No one is supporting them to eat in a more regular atmosphere now. And I think where measurement can really help is that person can continue to do assessments. And if they're having a really hard time or struggling, one, their clinician or a clinical supervisor, whoever's looking at that, can see that and maybe reach out to the person. But also if it's a family matter, and that's a reason that's coming up in assessment, it's a way to bring the family back in and work on things together. So I think that's like a really big piece that can have a large impact.
Steve, thank you so much. Being able to provide that comprehensive and continuous care, measurement-based care, really helps with that afterwards. Our next top question is, what does reliable change look like in an eating disorder setting? And I know, Wendy, you touched on this a little bit in your graph. So I wonder if there's anything you'd want to add on there.
That's a great question, actually. Reliable change, right? How do you know that what you're doing is really sticking and it's going to last? And I will say one thing. I have never seen a patient in my entire life, well, maybe one or two, where I would say, they stayed too long in treatment. You know, most of our patients, they're combating diet culture, weight stigma once they leave, and they're in our little protective bubble. So it's a really good, question. One of the things I think is good to do during treatment, and we do that really well with them because we're in the home, is do exposures to things in the community and have them have chances to do meal plating on their own, or going to the cafeteria at the dorm where they're at, or having a blueberry muffin at Starbucks with a care partner, and then maybe on their own, and just seeing how measures are doing as they're going on, as you're like rolling back your cord, and that the person's like gaining strength within themselves and gaining resiliency. So I think that is one way that I'm always paying attention, is I don't like to just treat somebody in one space and then have them leave. And doing measurement-based care through that process, as you're lowering down the volume of your treatment and making sure that the care is sustaining, even as you're gradually allowing them to take care of themselves more independently. I think that's what I do to try to get an assessment of that, is giving them more freedom. I always say freedom and responsibility are intertwined. You don't get freedom too early, though, just because you say, I want to leave. No, we have to see indicators that you're ready for that. But once you are, it's wrong to not let the person try, but it's also wrong to not assess how they did when they tried. So measurement-based care can really help with that.
Yeah, that's fantastic, Wendy. And I'll just add a couple of things. I think like from a direct measurement-based care perspective, reliable change means measurable progress, and not just feeling better, but actually improving in a way that hopefully lasts and can be tracked. And so I think like you can think about a few things. One is like maybe the most obvious, symptom reduction. So do they have less restrictive eating? There are fewer binge episodes. Is there a decrease in obsessive thoughts, as an example? Like those things are things that can be tracked, and we have standards in regards to reliable change and reliable improvement. In some cases, it may not be those things, and it might be about physical stability, if that's something that is necessary for that person, like reaching a healthy weight if it's needed, or reducing harmful weight fluctuations if it's a physical piece. But I think and then the third piece you could think about is functioning. So like day-to-day life. Is my day-to-day life getting easier, more enjoyable, less restrictive for myself? Are my interactions with family having less of an impact on my overall mental health. So those things are objectively that we can track, we can see the numbers on, but also dive into with patients to better understand patients or clients to better understand how they're viewing what the results look like and the experiences that are happening in their life and help make those better. So I think that would just be the additional piece I would add to like what rely
You know,
on.
You know what also is really interesting that I think is really useful with these measures? We were talking, I was showing you all the Rosenberg self-esteem scale. There's also the difficulty with emotion regulation scale, which we don't have yet, but these measures that are getting more into not just the overt behavior of the eating disorder, but the core belief systems that are actually potentially driving the behavior. That's one of the things I'm really excited about is adding on these other layers. And that's why I always liked the STAI, is that it really got into the thinking process and the rigidity with the thinking. And so any of these measures that go also beyond just the outward sign of the eating disorder and into the thinking process, I think gives you more comfort that they're really making sustainable progress.
Thank you both. I could just listen to this conversation for hours, and I know there's so much more that we could say. There are so many questions in the chat that are about harm reduction, how this applies to equity, how we can bring this into our practices. And while we do have to wrap up because we've hit the hour, what I'll say is we might have the opportunity to send out some follow-ups with maybe some next steps that you would both recommend or takeaways, slides, all of those different things. And so with that, I will say huge thank you to both of you for being here, for sharing all of this wisdom, this information. I can tell people were really engaged, had a lot of wonderful thoughts, and we will follow up with the recording so people can watch and follow up with our panelists if you'd like. And just really appreciate everyone's dedication to eating disorder care, measurement-based care, to improving these outcomes for our community.